Good afternoon, ladies and gentlemen. I work in Uganda at Makerere University, professor of psychiatry. So our involvement in this study was to look at how volunteer support intervention would help patients with severe mental illness in Uganda, and was a controlled pre and post study. Uganda, lies at the source of the River Nile, and that is the source of River Nile. With a new bridge that we have just built, one side is Lake Victoria, the other side is the river. That's the research team which collaborated with people here, some of whom you can see, some of whom you will hear about. So, low and middle income countries, including Uganda, often have limited resources to provide specialized mental health care, especially for people with severe mental illness. For example, in Uganda, the psychiatrist to patient ratio is about, to population ratio is about 1 to 850,000, meaning that in a country of about 45 million people, we have about 50 psychiatrists. Somebody said this is all the psychiatrists in Pakistan. In Uganda, it is a third of what is here. So the study aimed to assess the feasibility, effectiveness, and acceptability of volunteer support community mental health care, meaning befriending for people with severe mental illness in the Ugandan context. And the severe mental illnesses we dealt with were bipolar disorder, schizophrenia, depression, epilepsy. Epilepsy is usually treated by psychiatrists in Uganda by patient preference. So as we said with the pilot efficacy control trial, which we found after evaluations, where the study arm and the control arm, these figures of the patient populations and the volunteers were actually designed to be like that. It was not through calculations. We carried out these activities every 2 weeks for 6 months, and we measured the outcomes, quality of life using that instrument called MANSA, objective social outcomes using the 6 scores, treatment adherence, symptom ratings, and stigma. So what are the kinds of volunteering activities that we did? We befriended this patient with SMI. So, for example, we interacted with them and in attending churches, in games, in outings, in visitings, and socializing. We reminded them to always take their medications and attend for their medication reviews. We encouraged them to participate in income-generating activities. Have to remember that in Uganda, there's no social welfare for people with any illness. You contracted a bad illness or some misfortune in your life, you're left alone. And people with SMI tend to be neglected, stigmatized, and really forgotten in society, almost outcasted. So the kind of income-generating activities they engaged in were things like candle making, liquid soap making, baking, shoe polish making, simple activities. And we also made sure that wherever they were referred to any medical intervention, that they went there. So what were our findings? These were the main disorders that we dealt with, common in both the control group and the study group. What were the results? The quality of life significantly changed in that arm of the study where volunteering took place at 6 months and at 12 months. But in the control arm where there was no intervention, there was really no change significantly at 6 months, and only minimal change delayed by 12 months. Secondary outcomes. For example, the objective social functioning. We found that both in the control arm and in the volunteer arm, there was really no major change, and we shall talk about that. But in terms of psychiatric symptoms, significant reduction in those who received befriending or volunteering at 6 months and 12 months. And in the control arm, actually the symptoms increased. And by 12 months, there was no change between baseline and the end. Stigma and medication adherence seemed not to change very much in the volunteer arm, but the stigma decreased in the control arm and increased medical adherence in the control arm. We wanted to know what actually happened to get those results, but we think it has to do with the effect size. Now, what about the feasibility, qualitatively, of this intervention? One, the program was enjoyable to the patients, as you see that quote, by a male patient who said, I visited various places, I got new friends in life. The things I learned will help me if I put them into practice. Before, nobody could talk to somebody with schizophrenia walking on the streets in Kampala or in their villages. Volunteers seem to love and care for the patients. These were volunteers who had nothing to do with mental illness. They were part of the stigmatizing populace. And finally, they began to talk to these people. So one 20-year-old male volunteer said, my patients felt free to come to me. We had a pregnant patient, for example, who gave birth during the program. She visited us over phone. She invited us over phone to visit her home, and we took her gifts. Acceptability. Is it acceptable, this volunteer supported intervention? The community of volunteers accepted the program. For example, this one said, I benefited from the program. The program had impact on my life and in my community. It's now easier for me to talk to other mental patients and to my parents nowadays. I can easily refer such patients' health facilities for management. Management in my community now know, or the community my community now knows that I can help them with their mental issues. What about the patients? Did they accept it? One patient said, 40 years old, I was happy in the volunteer program. I felt at peace because volunteers showed us love and took very good care of us. I no longer consider myself mentally ill because of the good treatment I received. I remember in the past, whenever we were unwell, clinicians used to speak to us very rudely, but the volunteers treated us very well. Part of that is because these clinicians tend to be overwhelmed by numbers of patients with very little time. Was the program effective? Effectiveness of volunteer support intervention, purposeful reprogramming of life's routine. This 54-year-old single male patient doing voluntary support said this, I clean my compound and keep personal hygiene. The issue of moving from house to house to look for food stopped. I now discourage it. I can now cook. This is a patient saying how they benefited from the program. So what do we take home? Volunteer support intervention or befriending is a doable psychosocial intervention for SMI patients in Uganda. Community volunteers were able to work with the SMI patients effectively. Among the group activities include income generating activities, which kind of gave self-esteem and confidence to the patients. Befriending worked with our patients, and their participation were key in the patient care. However, working in Africa, working in Uganda, one wonders on how we can also involve alternative medicine providers, because many of our patients go to traditional healers and faith healers. Thank you very much.